What's up, guys? It's Josh. I'm going to go ahead and discuss my periodontology case study with you guys. All right, my patient, his name was Mr. Soso. He's a 25-year-old Hispanic male. Currently, or at the time, was seeking new employment and expressed having plenty of downtime to catch up on things. Hence the visit. It had been a long time since the last dental appointment. Mr. Soso currently resides on an out-of-town family-owned ranch with a significant other. City ventures are far and few between. Pastimes include smoking, some drinking, and tending to the property, just ranching it up. Chief complaint, the patient did not express any immediate concerns and just wanted to check in with his current oral health status. Medical history, the patient is 5'10", 115 pounds, classified as an ASA2. For the most part, he was very healthy, no existing medical conditions, but he did express having nervous or anxious tendencies. Diabetes also runs in the family. Patient's mother is a type 2 diabetic. At the initial appointment, his vitals were, his blood pressure was 125/80, respiration 17, pulse 82 beats per minute, temperature 97.6 Fahrenheit. Nutritional analysis. The patient generally consumes 2 meals in a day, sometimes only one due to occasional lack of hunger. Water intake is infrequent. He does drink teas and coffee. Mr. Soso does not particularly have a sweet tooth. Sweets are only enjoyed seldomly. Alcohol consumption is also occasional. Patient is a heavy cannabis user and smokes almost every other day. Objective data, extraoral examination. Extraorally, there weren't any significant findings. But getting into his intraoral findings, the patient did present with tori on the hard palate. His tonsils were absent. Gingiva was pink, stippled. The interdental papilla appeared pointed with some recession noted on number 3, number 11, number 14. That was noted up to 2 millimeters. So he had 29 teeth. There was abrasion also noted on 6, 11, and 14. That was because he would brush his teeth really aggressively. He also had a light yellowish stain that was generalized and plaque-induced. He had generalized slight crowding posteriorly on maxillary and mandibular anteriors. He had developing number 16 and 32. Number 31 was unerupted with impacted number 32. Lingual version as well was noted on number 23. Occlusion is class 1 on both right and left sides. The midline deviated 3 millimeters to the left. Overjet was 3 millimeters. Overbite was 2 millimeters. Posterior crossbite was noted on 2 and 31, and 15 and 18 bilateral. That was a bilateral posterior crossbite. He had a restoration on number 8. That was a mesolingual incisal facial composite, and that's a class 6. And number 7 presented with an enlarged lingual cingulum. So here's just all the pictures splayed out together. So regarding periodontal and gingival summary, the patient's gingiva presented as pink and stippled, pointed interdental papilla, localized areas of inflammation present towards the posterior region of the mandibular, particularly 18, due to erupting 17, with rolled and swollen margins. Plaque index scores show a high score due to lack of informed oral hygiene instruction. This was later addressed during the first appointment and has reported improvement from fuzzy teeth during first visit. Radiographs. The patient's radiographs showed no signs of alveolar bone loss with healthy levels of bone throughout the mouth. His diagnosis was generalized healthy with reduced periodontium, localized gingivitis towards posterior mandibular region, and he was a calculus type 1. Risk assessment. Local risk factors included crowding towards mandibular anteriors, lingual verdict number 23. And because he smoked cannabis regularly and brushed once a day, did not floss, and also brushed aggressively, that those were all risk factors. His treatment plan included dental prophylaxis to remove plaque, calculus, and staining. Oral hygiene instruction was also implemented to address improper technique. So as well, we went over implementing oral irrigators to address localized gingivitis towards mandibular regions, nutritional counseling to reduce carbohydrate-heavy intakes, and implement more water into diet to prevent caries. We also went over tobacco and cannabis cessation to prevent detrimental effects of smoke and heat into the mouth. Fluoridated aids were also recommended, such as fluoridated toothpaste and mouthwash. And we also sent out a referral to an oral and maxillofacial surgeon to remove the third molars due to impaction. The recall visit was 5 months to determine localized gingivitis. Prognosis: with proper evaluation and treatment, patient outlook is great. Patient's oral health is in good condition currently, but with current habits, or at the time speaking, with the habits he was, and the diet as well, he was really prone to decay and progress periodontal conditions. So it's a good thing he implemented all that stuff that we went over, and the end.